Okay. So, we have today and Friday. We'll look at some examples of different analyses and things. And one thing we'll do is we can talk about today is scheduling talks. I mean, so we have our talks, our final presentations on Tuesday, December 10th. I mean, the registrar says we start at 8:30. Given that we're not large, I'd like to start that at 8:45. It's most likely I can be in at 8:30, but if there's any delay or anything like that with traffic, then 8:45 is more sure. So 8:45 is just a little bit easier that way. We have one joint presentation, so there's seven talks in all. So if we start at 8:45, talks could be 10 to 15 minutes. It's not necessarily that you use the entire time, but there is enough time there to tell more of a story, give some outline of what you're going to talk about or how it's relevant, what you want to cover, some background. If it's data, you can talk about the variables, show descriptive statistics, get things warmed up so we know what you're talking about. Then talk about some different models you can do. So you don't necessarily have to jump to just a quick conclusion, and then do kind of a summary of what you've learned. You can speculate about what you might like to, what other variables you might have had, or other directions that might be interesting. So it is, a little bit more time. That said, if you prepare 10 or 12 slides and say I, really only need about 8 minutes to get through this, that won't be a problem per se if you're telling kind of a complete story. But you can think about that. If you prepare 6 slides, it's like, well, I can get through this in about 5 minutes. Well, maybe think about it. What can you, more of the story can you tell? What can you enhance it? If that means more speculation or more, here's the real basic things that would come before doing something more complex, you can do that. But then, we're scheduled to go till, like 11:30 or something like that, but more like 10:30 we would likely be done if everybody does 10 to 15 minutes, right? So there'd be 7 in all. Does anybody have a preference for going early versus late, or, yes?
Can I go earlier?
Go earlier?
Going first?
Yeah.
You want to go first? So Connor spoke up first. You want, yes?
Yeah, I'll go.
You also want to go early?
Yeah, I can go, yeah.
Yeah, I don't.
So Annie and Courtney, right?
We can go after.
You can go.
I
I want to get it done. Yes? You want to go?
I'll go next.
Go next, okay. Dan. Yifei? So we'll put, Zhang is well, anyway, that's another issue, but we'll put him there. But anyway, that's something for me to think about why he's not here and so on. But that's just not relevant for this, but we'll put him on the schedule. So, right. Great, so we'll plan to do that. And so that's, this is the Tuesday, December 10th. And I think it'd be very interesting to see, the different things that you have to present on projects that you're working on. I think there's going to be a diversity of topics, some growing out of things that are in our class, some that are different. So John Lee, we put you on the schedule. This will be on Tuesday. These are the final presentations. So you're on there. The second thing I want to talk about is, just get some other topics. Certainly we've not talked about all statistical models. There's rich statistical models in many areas. And really when you get into a specialized area and start looking at things in detail, then you deal with more complexities, more variance structures, more things dealing with non-independence, more use of different variables and so on. One thing that I don't plan to talk about in detail is chapter 22, is something called Poisson regression. This and logistic regression are in the general framework of generalized linear models, right? And it's where a linear assumption relating x variables to a y directly doesn't necessarily make sense like it does with logistic regression. 0, 1, you don't want to predict things outside of the 0, 1 probability, so we did the logit transformation. But the general thing for a generalized, so in this case, the yi is Poisson, lambda I, and you want to relate that lambda I to different x's, right? But lambda I is greater than 0. So if you just do predictions, you could end up for some x's doing predictions below 0. You just did it linearly. So you don't do linear regression for that type of data. Instead, you could do the log of lambda I as linear. And you can have a bunch of different x's. And it functions much like logistic regression, or the general concerns that you would have with ordinary regression could be there, but it's done through this link. It's done through a likelihood function, and you get deviance residuals like we did for logistic regression, and so on. Sometimes this is done where i's really are different areas, and you have counts in different areas. The areas are different sizes. Counties are different sizes. School systems are different sizes. So sometimes it's rephrased a little bit where you have an exposure size and then a rate. And so lambda I is something like cases per 100,000 or per 1,000 or whatever the appropriate size would be, and E is like an exposure, which sometimes is something like population size. So of course you're going to get bigger counts in bigger areas, but the rate at which things happen could be related to characteristics of that area. Density, poverty, other environmental things, and so on. Employment rates, and so on. So anyway, you can do this thing, and then it goes through likelihood and things. The general, there's an example in the book. If you work through some of the case studies there, you would see that is. But the point is that often for different models of different data, it works to do a certain transformation to make things linear and work out. There's some deeper theory in generalized linear models, and many graduate programs would have a course in this, that often what is the Poisson link, the probability function for a Poisson, the probability that a value equals this for Poisson is there's a lambda to the y e to the negative lambda over y factorial is a Poisson probability. And kind of deeper under coming up with these links is where do the data and the parameter really interact? Where are they really together? Where they're really together in this function here. The data are here, the parameter is kind of separate over here, but here's where they interact. And if you rewrite this as, there's an e to the negative lambda over yi factorial, this other part, if you put an e, then e to the log of y, of lambda y, is the same as lambda to the y. These two things are inverses of each other. But the log of something to a power, you can put y out here, right? And remove it from up here. Right? And so there's something here. Well, here's log y. Right? It's kind of the sufficient, here's the version of the parameter that is linear in the statistic. And so it happens to be log, oops, racing as I go, that this link function that shows up naturally in the density ends up being the one that gets used in these generalized linear models. So there's some neater theory about how the density functions translate into that. So we're not going to cover it in detail, but there's an example in the book. If you have a senior project or a project of some time where it's kind of this count data, maybe that would be a relevant method to do. But we would do the same thing. Estimation, confidence intervals. If you estimate things on the log scale and then exponentiate them, you get back to the original scale. So we would do that transformation. Then we would do diagnostics, different residuals. How do you test different coefficients? We would do the same stuff, but with this other model. There's a few other areas that, if you look at other areas, that if you wanted to look at statistical models, I think would naturally come up as next steps for many of these things. So a general study of generalized linear models. There's generalized additive models. So these are generalized linear models. And so the GAMs, the generalized additive models, are, not everything is a nice linear curve on any scale, but rather there's kind of up and down and more variability. So people do, this is in the class, kind of the bigger extension, the more modern extension of things of just trying to draw a smooth curve that goes close to the data, that can be wiggly, or according to some criteria, right? So you can do that in analogous to linear regression or logistic regression, and have these very flexible curves there. There's a number of things that are modeled as mixtures or with some type of latent structure. That are there. So mixture models, you observe data, but really it comes from different groups. Right? So you don't model it directly. You say, if it's in this group, here's a model. Right? Here's a normal distribution for it, if you knew which group it was in. But then the trick is trying to determine which observations belong in which groups. Right? And if you have enough observations and there's enough of a pattern, then the groups separate. But they're probably going to overlap a little bit. Right? So there's ways to estimate that. Right? So it's you set up models, generally with latent structure in psychology or education measurement. There's some underlying core concept, intelligence, right? or happiness, right? Or satisfaction or something. And you can't measure that directly, right? It doesn't really you don't get very good information if you say, are you happy? But if you ask a series of questions, how do you feel about this? How do you feel about that? How do you feel about your life prospects in some aspect over the next year, right? You psychologists, sociologists, work at that to get good questions that relate to underlying concepts. And so you measure all these variables and then try to infer concepts that could produce patterns there. So those are interesting models that are quite different, but useful in a variety of things. And so you do diagnostics. You have a certain number of mixture components, a certain number of latent concepts. How strongly are they related? Do they predict the data well? Is it goodness of fit? What percent of variability is explained? So many of the things that we did in linear regression have their counterparts in this and their interpretation. And then, to me, a very interesting area is hierarchical models, where you have multiple levels of measurement. You might have individuals within schools, within school districts, within states. Right? And there's characteristics, variables that pertain to every different level. And we had kind of like random effects models, but kind of souped up randomized effects models. There's many more things to consider. How many variance components do you have? Are there correlations in there? How do you use different variables? How do you design a study to be effective in that? So there's a whole realm as you get into much more advanced things that are there. So we've touched a lot on models and tried, I think the book does a good job of thinking about the questions you need to ask. Right? What does the model mean? Is it appropriate for the data? How do you fit it? How do you interpret coefficients in there? How do confidence intervals? How do you check it versus the data and that sort of thing? Right. And so in these other advanced areas for different types of data, you'd have different models. And so and you try to learn from those different things appropriately. Right? But what I wanted to do to kind of finish up today is look at an example. It's a project that I worked on at at George Washington University. It's actually still kind of ongoing in a way, about something called bacterial vaginosis. And it was something called an individual patient data meta-analysis. So there's a talk I've kind of given it to a couple different places, but I think it's relevant for this class because also chapter 23 in the book talks about the whole research data collection process. How do these models, they fit in a certain place, and the design and so on, but it's part of a bigger, arch, an entire picture. And so this will talk a little bit about that, right? So I hope you find it interesting to think about the entire thing, and so I think it fits in with what we're doing. So there's a medical issue. Some previous studies have been done, and people have done meta-analyses to bring together results of different studies, but there's some limitations. So to answer this, we needed to get individual data to answer our more complex question. We have different statistical models we use to analyze these data. And then there's some question about sensitivity of results to certain assumptions. And missing data is a critical component, right? And so we'll see how that works out. This is I work with other people. When you start getting into these larger data projects and models, often it's big teams that are doing it. Mark Klebanoff at National Children's Hospital, and some people at George Washington University, and a collaborator who's in the Netherlands, and other people were involved too. Mark Klebanoff connected to George Washington University through a maternal fetal data network. So it's groups of hospitals across the country and in other countries too, who come together to try to do studies on mothers, newborns, the birth process, and so on. Right? So that they to do these studies and get large representative samples of patients, they take things from 25 different hospitals across the world, right? And then collect their data and in systematic ways, and then combine it for analysis. So that's already done for just one study, and then they keep studying over time to do different things. Right? It was funded by National Institutes for Child Health and Human Development, and there's usually a disclaimer that these are my ideas about it, my responsibility, and you can't hold anybody else account for my mistakes, right? So, but the medical issue is about preterm birth, right, which is birth before 37 weeks of gestation. It's a cause of infant mortality and has many other implications for the child development and health of the families. Infections, interuterine infections, leading cause of that. Bacterial vaginosis, or BV, is a particular type of that, where there's really kind of an overgrowth of diverse, probably anaerobic microbiota. It doesn't necessarily cause catastrophic impacts or things like that, but it's associated with premature birth. Asymptomatic BV has been studied, kind of in observational studies, right? And is associated, adjust for different factors, women's age and number of previous births, and smoking status, and things like that, alcohol status. But it's still associated with an increase in preterm birth. So it's asymptomatic. The mother doesn't have pain, doesn't have other symptoms that are really, but it's there, right? There's an overgrowth in bacteria. And so the question is, does treatment early in pregnancy prevent preterm birth, right? Or lessen the chance of preterm birth among women who are asymptomatic? Now, if a woman's symptomatic, you treat, right? If the woman's coming in with pain and other symptoms, they probably do something, right? Bacteria, antibiotics to avoid that infection, right? And so there's been a bunch of randomized clinical trials that have been done. There are a number of kind of observational studies that say, that we were focusing on clinical trials because that's a better standard of proof. So there's some treatment versus placebo, or sometimes simply control. The randomization is important to remove this bias due to confounding, because if the primary care physician just treats some women and not others, they might treat the women who they're asymptomatic, but have more clear signs once they're in the clinic, right? And they don't, if it's observational, then it's harder to say, it's harder to do. But there's been mixed results in previous research. Now the antibiotics do reduce infection. I mean, that's clear, right? But whether it prevents preterm birth, that's less clear. There's different regimens of treatment, different diagnostic criteria for bacterial vaginosis, different inclusion criteria. So some included women only with previous preterm births, others included women who have never had births before. So, and there's also different populations and countries involved. So it wasn't completely clear about what to do. Meta-analyses combine results. And so a traditional meta-analysis might just take summary statistics, right? Test statistics and p-values, and along with the test statistics, an estimate of the effect of treatment in terms of delays, in birth, increase in, or impacts on an odds ratio or something called a hazard ratio, and then a standard error for that, right? And so it can take a weighted average of these estimated effects with weights proportional, inversely proportional to the variances or the square of the standard errors. Right? So imagine you have a bunch of t-tests for different populations, you just kind of put them together, and the ones that are more precise get more weight. Right? If they're more precise, they probably came with studies with bigger sample sizes, so they get more contribution. And so that provides a new analysis. There's an organization called the Cochrane Review that does systematic reviews. That is, they will employ researchers to find everything they can, all the trials they can find about the topic, pull out all the reported results, and combine them where they can, right? And so there are 21 trials involving about 8,000 women, and this concluded, reduced infection, but did not clearly reduce preterm birth, and the conclusion was just general screening for asymptomatic bacterial vaginosis wasn't worthwhile. Right? It wouldn't necessarily have a positive benefit, right? But there's limitations to these things, right? Different studies reported different gestational age cutoffs. Some were preterm, some were early preterm, like less than 34. There's one that was 35. Most didn't break out by gestational age at randomization. So if a woman's treated at 10 weeks versus 15 weeks versus 20 weeks, 20 weeks, you're that much closer to being a full-term birth, right? You're 10 weeks closer. So the women can be quite different. They didn't necessarily include the same risk factors, previous preterm births versus preterm pregnancies versus no nulliparous, no previous pregnancy. Some included smoking, some did not. Some included mother's age, some did not. So they were really different that way. Some included diagnosis of bacterial vaginosis, but were really focused on other infections. So the entire study wasn't just one group, but right. So you couldn't really tell. So, but the goal we would like is what's the impact of treatment of BV, asymptomatic at-risk women early in pregnancy, and so that's not really answerable with the meta-analysis. You get a general answer, but it can't be that specific because not every study was reported the same way. So, but if you have the individual data from all the studies, right, you might be able to do that, right? So we did, or rather the medical collaborators, Mark Klebanoff and Steve Weiner, searched through the Cochrane Review. There's clinicaltrials.gov, so you can put in bacterial vaginosis or preterm birth, look at the hundreds of studies that are listed there. Medline, there's some key journals, Journal of Obstetrics and Gynecology, for instance, and others, Web of Science, and then references to those articles to try and find everything. Right? There's a UN clinical trials thing as well, I think. And so out of those, they looked for articles where they compared treatments. There are a lot of articles that would say, take metronidazole at this dose versus metronidazole at that dose, trying to get safe dose. But that doesn't really answer the question, is it better than no treatment? So, or they would only report, did it reduce infection? They didn't follow women until preterm birth. So there's a bunch of studies that do important work but are not useful. So they had to state how they diagnosed by BV. Some just said, it wasn't clear how they chose the women. Right? And they needed gestational age at randomization and at birth so you could tell those key things. There were 96 studies that were randomized clinical trials. 23 of them were eligible, and we contacted them, and 13 of them provided data. So we got data for almost 7,000 women. Data came in Excel, CSV, SAS, SPSS, Lotus Notes, an expired Lotus Notes version. It's like, great. But anyway, so the computer science team figured out how to get these things converted mostly into Excel files or SAS files. I was using R. Some of the other people were using SAS there. And so we kind of did things separately and see that we got the same numbers and so on. So. But I think in the biostatistics world, SAS has been so dominant in clinical trials, data management for so long that it's there. But R is certainly used heavily now for many analyses. So I see a mix in practice. And in addition to the data, there are published articles for these things, right? Published articles have sample sizes. They have results broken out by different things, so you can tell so you can check, do the data that you get actually match to some of these studies were 15, 20 years old, and it was maybe a secondary person that was still alive or working someplace that could provide data. Some of the studies we didn't get data for, everybody's gone, right? 20 years ago, the researcher was 75 doing the research. They're not around. That clinic doesn't exist anymore, right? The computers don't exist anymore that the work was stored on. So some of those, a couple of them were in Italy or in Iran, couldn't contact people. But there's articles, abstracts for medical things are short statements of results and have a few things in here. They're usually accepted and then presented at conferences, right, in advance of papers coming out. And there were a few data code books, right, or data collection forms. So we had to figure out what the variables were. Some of them just had, V1, V2, V3, V4. It didn't have column names. But by kind of doing a little detective work, you can kind of figure out, okay, if there's supposed to be 323 treated women and 279 not treated women, and then this number of this group and this number of this group were preterm or not, right? You can figure out some variables. Okay, and here's something that looks like ranges about 2,000 up to about 4,500. Well, that's birth weight in grams, and so on. And then there'd be summaries of the individuals, so you can kind of figure out. It translates some languages. Duwit Schuit is Dutch, so he took care of that one. But there's one study in Afrikaans, so you Google Translate some keywords that are in there. 3 of the major products were like GW, so certainly the people doing it had some expertise in what to look for, what type of things were done. There's something called a risk of bias that is kind of a formal thing for reporting how studies are different. There weren't any studies that looked so incredibly different. There's some that were slightly different, but they were all kind of in this general vein. That in the field, how to diagnose and how to treat bacterial vaginosis in terms of the type of antibiotics there was only a few variations, so it wasn't so strange. But what do some of these things look like? So one of the studies, here is the data collection form they sent. So this was what they had in their study, and they kind of circled where history of preterm delivery, yes or no, preterm, some of these things. Was preterm delivery indicated, yes or no? Why? They did an exam and collected these things. Right? Diagnosis of BV was a variable. I guess they didn't put those things. They used antibiotics before conversion. So this is what the researchers at the time had, and then they're going to interview each woman or look at their medical files and collect things. So we got this. And so when we're looking at the data file, we're trying to match this up to things that are there. So going back in time, right, number of pills used, compliance, and so on, for different things. So anyway, we could get something like that. A few of the data sources like SPS or SAS have the data, but then appended with that in the computer program is a translation of what the variables are. So you can see, here's one of the articles. So when you get an article like this, so this was this big group of people does these studies. Mark Klevanoff is here as the second author of that one. So here's this network of maternal fetal medicine units, this MFMU network that brings people together from different things. Researchers also at National Institutes of Child Health and Human Development. So within the National Institutes of Health, they have about 4,800 PhD researchers internal to NIH, National Institutes of Health. So an article does, there's a title, it gives a little bit of information here. So you get sample sizes, some percentages, and so on. It states kind of the importance of the problem, methods, how do they get the women in, 8 weeks to 22 weeks, 6 days of gestation is how some of their entry criteria. In this, it'll say whether they allow, women with previous preterms or not. What do they exclude women for various complications and so on. Definition of how they know that they had bacterial vaginosis. Here's some different coding of that. How do they do randomization to treatment versus non-treatment? How do they assess the outcome? This is how they give these tables for how they get 1,000 women or so. What was it? Yeah, 1,953. This was a bigger study, one of the biggest that was included. They started with looking at records for about almost 30,000 women. Right? Some were ineligible for screening. Some refused consent. They got consent. Can we screen? So 22,000 were screened because this is asymptomatic, right? So they're pregnant, but they're not showing signs, right? 7,000 with. They did want them without this one ISS. Some of them were ineligible, some declined consent, some didn't show up for randomization. Some results were reported too late. And so they ended up with 1,953 that granted consent and randomly assigned. So it was a huge operation that could take 6 months, 6 to 9 months just to get ready for this. And they probably wrote the grant a year before that, at least. Right? They talk about what statistical analysis they're going to do, and then some results. So they describe baseline characteristics of the patients. So from that type of table, you can kind of deduce what some of the variables are. Right? You're supposed to have 966 and 987, and then marital status is supposed to break out by different things. So even if you don't know what the variables are exactly, with enough information in a table. Now this article has a lot more detail than some. Some was kind of sparse, so it's a little harder to know. But anyway, and then they have their results, and they do a kind of a survival curve, right? Gestational age at delivery versus percentages at delivery. And so it's declining, and the p-value here is not significant. So this study concluded that metronidazole didn't make a difference as the antibiotic in preventing preterm birth. Right? So 37, 35, 32 are cutoffs by birth weight of the child and so on. And then some discussion, and then looking at other subgroups and other specialized groups by different risk factors and so on. So you get an article like that, it has a lot of details, but it doesn't still answer that particular question. If you treated women early, like 10 to 15 weeks, who were at risk, would it help? It doesn't help overall, but for that specific group that is the most, maybe it would. So you take all that information, right, and so you also have to think about ethics of this, right? Is it legitimate to do this sort of thing, right? To go back and take people's data. There is an organization called Prospero. So it's a prospective registry of systematic reviews. Just like people register clinical trials, when you're getting ready to do one of these big reviews, you publish, I'm going to do a review. So that people expect a result to come out. If no result comes out, they'll know that something happened. If there's a, it gets kind of a cap on the number of things that can be investigated but not reported. To get in a major journal, they'll want this, right? So we got de-identified data. There were protocols. The GW has a data coordinating center, so it has secure web environments, secure computing, locks on the doors. They ask about all this stuff, right? Is the computer center inside the research center locked? Yep. It's locked. There's an off-site storage in case of catastrophic accident or something. It was the DC area, so terrorist attack or something like that, or the back 2000, the early 2000s, there was the SARS outbreak, so flu, like in Hong Kong and then Toronto, and it was very infectious flu, and so then we were told, be prepared to deliver your classes off campus, because if the downtown DC area gets infected, we're going to send everybody away. So you kind of have to, anyway. So yeah, no, all that security. The Institutional Review Board at GW said it was okay. It's secondary data, de-identified, no risk to previous things. The meta-analysis working group reviewed it and said, yes, this is a legitimate thing to do. It looks like you know what you're doing. And so we got the data. Right? Recoded things so that all the variables matched up across the different things. Right? And we primarily used logistic regression to predict preterm versus term birth. Right? So is it preterm or not? One being preterm. There's also a survival model, which would be an enhanced model, right? That says what's the probability that a result happens after a certain period of time. The logistic regression was 0, 1. This one, we had length of pregnancy, but for this type of survival model, we don't really care if it goes to 38, 39, 40 weeks. So we actually capped the length of pregnancy at 37. And if you don't do that, then the ones that are really long have more influence on the entire curve. Right? Anyway, predictor variables, treatment versus placebo control. Also, the drug. There's two primary ones, metronidazole or clindamycin. 3 classes of women in terms of their obstetric history. When were they randomized? We could have had an interaction in there. And then there's study, right? Ideally, we would have included more information. Mother's age, smoking, alcohol, and whole lots of other different things. But across these, 10 or so studies, it was very hard to get variables that pertain to all of them, right? You get 5 of the 10 have smoking. 4 of the 10 have alcohol or drugs. We're not actually sure how they really reported alcohol and drugs in there. Was it a really good measure, or you just ask a woman if she's, self-report? It wasn't really that necessarily scientific. And then other things about history. Some women had this complication or that complication, but they didn't exactly say how they knew. And then you have 2 studies report on something that might be interesting. So it was really kind of reduced. Right? So much more you might like to know. Right? Twins. Right. Some studies allows mothers with twins in there. But we could figure out a variable that would indicate they're twins. There'd be the exact same mother characteristics, the exact same, almost the same birth time, sometimes the same birth time. Sometimes the same mother ID, right? Sometimes an explicit variable that said twin, right? You don't want both twins, really. There wasn't a very big portion of the data, but they're not independent of one another, right? If one's born, then the other one almost always is born quite quickly after that. So we could analyze it both ways. You could say, we're going to analyze the data and include all twins from the analysis. And if you do keep a twin, maybe you just keep one record. Right, so that a single mother doesn't contribute twice and violate independence that way. Right? Twins are usually born a little earlier anyway because it's bigger stress on the mother. So we use logistic regression, right, to predict the 0, 1 outcome. preterm versus not. We know this type of model, the logit, is a function of treatment, randomization, gestational age, indicators for is there a previous preterm birth or is there a previous term birth? So the third category that's left out is the women who had never had babies before, never been pregnant before, nulliparous, right? And then a random effect for study. About 10 studies. There's other systematic differences between the studies that can't be captured in all this, and so one way to account that is put a random effect in there. And so e to the beta 1 here is an estimate of the impact of the treatment on odds. And the way we've set it up, less than 1 is good, which means less chance of preterm. The other model is something called Cox proportional hazard model. It's kind of a baseline risk event per unit of time. And then that is modified by the x variables. So it could be a higher risk for earlier birth among some groups and lower, right? It can be continuous, categorical x's. And so we estimate beta uses maximum likelihood, and e to the beta 1 is an estimate of the impact of the treatment on the hazard ratio. And again, less than 1 is good. Reduce the chance of earlier birth. And the outcome, because of what was capped at 37, because we don't really care about getting that point, that's the finish line, right? Could you use linear regression to predict the length of gestational age? I mean, you could, right? I thought you could, right? It made sense to me, but it wasn't really so desirable to clinicians. They didn't like thinking about predicting the number of days. Sure, you could look at the number of days that are different, or maybe you could even cap it at 37 and see kind of that benefit, but they weren't so interested in interpreting that. They wanted the probabilities or the survival. In their world, that's the model they work up with, and so it made more sense. So, drug had a significant effect, so these two. So if you enter it as a predictor, it had a big effect, right? And so much so, so if you entered another variable like the previous preterm, you probably would want to have an interaction there. So you're building up this kind of big model with all these things. And so it's decided just to split it into two analyses. Analyze the metronidazole studies separately from the clindamycin studies, and just make it simpler that way. Otherwise, you have all these interaction terms to keep track of, and it was a little harder to report. Another thing that was, we're interested in early and late gestational ages, and so with the original data, having the individual data, we can split it. We can just take the ones that were randomized early, when they're younger, earlier in the pregnancy, and then analyze them separately. So we could look at it a number of ways. So there's, and also, the ones that had risk factors. We could take just the women who had particular risk factors. Part of this is a check on, does it make a difference of which group you look at. But there's something a little subtle, right? So if you combine data and have like an effect, right, for risk factors and an effect for gestational age, each of those is kind of averaged over the other categories. Right, so if you have the effective gestational age, it's kind of averaged over this in the model, even if there's a effect of that's in there. So that's why we look at interactions, possibly. But it gets kind of complex to have that many things. So anyway, you could look at it multiple ways. We kind of want to get a consensus and learn as much as possible, so multiple models make some difference. And there's some other interactions we could put in there. There's treatment. Have that, and so we can look at those patterns. The thing else we could do is do single studies really make much of a difference? Right? So some of the studies looked a little bit different in the results than others. They either had much higher rates of preterm birth or much higher rates of other complications. And what are we doing on? We'll finish this story, but we have enough time for that, right? And so you could actually take out the data from one study and analyze all the others, right? And see if it changed. It didn't really change the analyses to do that. That was a lot of work to do, writing a little loop in R to take out one study at a time and rerun analyses and spit out the results. We had the individual patient data from many studies, but in this area, there's also the summary data from the other studies. We didn't have the individuals. is there any way to use that information too? Some people do things where they do kind of a two-stage model. They take the summary data and estimate something, and then use that to inform some parameters, and then they analyze the individual data for the further analysis. We wanted to put it all together. There was some change in results, and that's been kind of the controversy of getting this published and getting it reviewed, is that when we dealt with the missing data, because when we don't have the individual data and just have summaries, we're missing the details, right? It caused an issue, right? So there were, of the 10 remaining studies, 9 actually had useful summaries that gave enough information so you could tell what the results would. They gave things like the number of women in both treatment arms, number of premature births in each one, and which drugs they were taking. Sometimes the results were split out by risk categories, so you'd have a little more details, and so on. They usually gave ranges of gestational age by enrollment, maybe even average of standard deviations. They gave things like mother's age, and so on. And sometimes there are other variables. But you know, sometimes things weren't crossed. They'd say 10% of the mothers were smokers. But they wouldn't say 8% in this group, 9% in this group, and they wouldn't break that out further by. That wasn't their purpose in their article. That was too much detail to report. So we generated pseudo data. Right? We multiply imputed for the missing data. That is, we only have summaries. We can think of those as missing. For those studies, we set up a donor set. All women with individual data who are like those in the summary study. Right? So they had the same risk factors, same gestational age ranges, and so on, same drug treatment. If they were clindamycin, we looked at the clindamycin studies and so on. So we randomly selected women from the donor set to represent the women who were missing. And that's something called hot deck imputation. It's used in government surveys all the time, and that's why I knew about it from working with surveys. So when you do this, we can match the sample sizes and a lot of the characteristics. Right? We can get exactly the same number of women in each set of imputations that got treatment and control and then had a preterm birth or not by group. And if there's another value where they give us more information, we can match all that too. And we can get close with some kind of simulation techniques to kind of get close to the average age and other things. So we created 5 sets of missing data. Right? We analyzed the completed data, the imputed, the individual data we have, plus 1 set of imputed data to get an analysis. We did that 5 times. And then there's some rules for multiple imputation for combining those things to represent uncertainty. Right? If you just fill in the data and pretend it's all real, do it once, that's overly optimistic, right? If you do it 5 times and there's this extra variability, you capture that through a few rules. So that was an idea, kind of a novel idea. And these are some figures that come out of this, right? This is the metronidazole drug versus control. And this all here, this is the individual patient data only, 4,000 women here, and that's the result, right? 1 is no effect. Metronidazole, and this is the logistic regression because it's the odds ratio, right? No effect on preventing preterm birth, right? This is when we added the imputed data. There are about another 500 women, so there's another study where we had summaries and they used metronidazole. That study was a little more, optimistic, but still it's at 0. This is kind of it's kind of a log scale, or not an even scale, so it shows that is standard, even. But anyway, still nothing. And this is by gestational age at randomization, right? And by different gestational ages, there was nothing there. Odds ratio estimate, confidence interval, all presented there graphically. No effect, right? And this is the hazard ratio from that survival analysis. Again, really, really nothing. Some of these were not calculable. That is, the software couldn't come up with an estimate. There were only 32 women who were randomized before age 15 in these studies. And so you would get, in logistic regression, you get these problems. So if everybody in a group is premature or not premature, and there's nothing there, you end up with this discontinuity, and it just doesn't calculate. Right? You need some success and failure in both groups to even be able to estimate the parameters. And then you couldn't, then you cross it with treatment, cross it with another factor, and so just 30. It just wasn't such a small sample size. You wouldn't learn much anyway. So metrocytol, no way, right? This is clindamycin. These studies were generally done with younger mothers. Overall, about 2,000. And this one looks like, that would be significant. A 0.62 odds ratio, right, like that. But there was a very large study that just was done in France, which had negative results. So if you do our imputation scheme for those, that adds about 4,000 women, and now our interval's over here, right? That includes 1, no effect. These were younger, and both of these kind of split by age don't really have that. Hazard ratio, it wasn't quite significant here. You add in the other data, and it's very narrow estimate, but it's 0.99. It's really right at 1. So the hazard ratio doesn't really show any benefit. Logistic regression, depending on if you do that imputation, kind of try to recreate those data, then it doesn't seem to have an effect. So our conclusion was there's not a proven benefit, right? And just general screening for asymptomatic BV, even in high-risk women, doesn't really seem to have a benefit, right? And so this was the right. Okay. So, the goal was to combine information and learn something from these separate randomized trials. It was a pretty major effort to get the data and combine it. Models we've looked at, well, and then survival, but random effects was important to that. Missing data was a big issue, and it appeals that screening and treatment are not warranted. Metrocytol, definitely not, but clindamycin is kind of at the border. But even if it were significant, what does that affect? If it shifts over just a little bit, and so it's between 0.96 and 0.98, it's a small effect. If you're going to screen around the world for this, that's a big cost, and it's just, right. But anyway, the status of this thing now is that big study did publish its results, and so they said, why don't you get the data from that one? And and then and by the way, there's these couple others that had little subgroups that wasn't their main focus, but the reviewers knew about a couple other studies that don't show up because they don't appear in the literature as ones for treating bacterial vaginosis, but they did report results by that subgroup. So we can add in a couple more studies. Maybe we won't be able to get that, and they want a little more discussion of this imputation method really work. Fortunately, with the original data, we can leave out any study we want and look at the summaries and try to impute for that one, right? And then see if we can do that 10 times with the 10 different studies and see if it works out. So there's some more work to do. This has been a multi-year effort. It was about a 3-year effort to get funded to do it. And we did the analysis over the course of a couple of years. And then it's been kind of sitting around waiting for data for a couple of years. So, over the course of 10 years, we'll probably get an article out of this. So it's a long-term thing, but it's been, just one thing going on. Right? But yeah, I was going to give this talk at Bennington, but it didn't work out there. So maybe I'll go down and give it there sometime as well. But the other type of things that you make for these things are tables. So this was kind of the characteristics of the different studies providing individual data, treatment versus placebo. Less than 1% twins, that wasn't significantly different. Nulliparous, these different categories, including missing, that ended up being slightly significant, but we can do a random effects testing because there's kind of clustering different by that. So once you account, it was a significantly different, so kind of imbalanced. But once you kind of account for the clustering, a random effects thing, it wasn't significant. Right? So we needed to use that. And you can look at other characteristics of the things that were there. Right. So there's work getting that ready. Let's see where this one go. We created tables of effect of treatment on measures of pregnancy for the clindamycin, the CM1s, right? So, you know, out of this number of treatments, number of controls, an odd ratio for treatment effect, and a p-value, confidence intervals. We looked at some interactions between gestational age, and so there were some interactions in these things, but the estimate of the effect is still that you could look at time until birth, which would be the survival analysis, and then logistic regression for 37. Once we have individual data, we can use 37 weeks, 34 weeks, 32 weeks, and look at the different ones. And generally, just it didn't show up as being significant. This one just slightly, just at the border, but I guess this one, some of these ended up being significant. But this is with just the individual data. Once we added in the imputed data, get a similar table, but it wasn't quite significant. But the effort involved, so we had some supplemental tables where you can break it out by different groups. These are kind of work in progress, by different categories. Here's the different studies. Here's if you exclude one study. So there's a lot of documentation, a lot of analysis to get to the point of getting ready. So we're going to actually do some of this again if we get the new data. But I think one more pass through and then it'll be quite convincing. But so uses models that are slight extent. Well, logistic regression with random effects is quite similar to what we've done in this class. It can be a couple of years of preparing data to do that, and then running it many times for different variations and organizing it into a coherent story. But that's what we allows you to try to answer that question. All right. Well, so I think on Friday maybe we'll look at another example, but it'd be a good time for questions, follow up on things. If there's general questions about projects and things like that in presentations, we can talk about those. Real specific things about your own one. I'll be around this week to meet or answer questions via email, things like that. I'm getting drafts of things, comments about things, so I'll send some comments back if you do those. Good. All right. Well, thanks.
Research papers done, so that's not a good smell. It might end up being 15 pages long.
Yeah. For my assignment, would be like, my model is 25 pages of mostly equations.
Oh my god.
So yeah, that's what I work on Monday.
Yeah. Yeah.
But
Based on, if there must be a variable, right? So 1520. Let's see if I can comment. So put down here, randomly chosen sites and then nest sites. So predict this versus that. So having a 1 for like the nest sites and then the 0 for these sites. In that variable, does it have a doing logistic regression to predict nest. So this one, right? Nest is 0 or 1 variable. Presented based on percentage and radius. it looked like percentage is a significant predictor of the probability of being in one of those groups. And model 2 does that. These, those, yeah, there's probably a test of deviance that's done there. Does that help answer your question, focusing on that next variable as the outcome? Do you have a project that you're working on?
So there's a deal though, so I bought the package, it's $12 for the Hulu Disney Plus
Okay.
and
It's trying to be the whole project.
Okay.
I have it, it's first thing it makes my boyfriend happy, candy. Yeah, and that's free, right? Yeah.
Okay. Yes, I'll be in tomorrow.
Paying everywhere.
I will check the whole project tonight.
Yeah. If you send it to me in the morning, maybe I can look at it and we can meet. What time is good to, like early afternoon or something?
No, my dad would be like, everyone like put your clothes on, we're going to the movie store, we go and sit.
Okay, yes.